Hello, everyone. This is Howard Mann. Jeff is off this week, so we have cases from Brent and Travis, and I have some cases as well. So let's start with Brent this week. So I'll give him the screen.
Okay, can you see my screen?
Yep, we can. Good.
Okay. I have a couple of fast cases and then a couple other cases. So this is just a reminder of what a particular entity looks like. This is a right lower lobe posterior basal adenocarcinoma here, and this is at time point 1. And I'll show you a CT that was done at time point 2. Apologize, I will go back here. Okay, this is at time point 2, and I'll scroll down to the same area here. And you can already see that there's a much different appearance of this nodule, the soft tissue nodule in the right lower lobe. And now we have this kind of peripheral halo, some ground glass around this, and kind of a rounded appearance with traction bronchiectasis going to this lesion. And so one concern would be that, if I told you this time point was a year after the first time point, that this adenocarcinoma had grown significantly. But I'll tell you that this was 3 months after that first time point. And so that really doesn't make sense, that degree of growth in 3 months. But the history, of course, is after treatment. And this is just the typical kind of subacute 3-month, 2-3-month appearance of SBRT, stereotactic body radiotherapy, where you get a ball of developing radiation pneumonitis and presumably some organizing pneumonia in here as well, and some early fibrosis. So it's just a good reminder. It's always important to know what treatment the patient had. And the interesting thing about SBRT is that it tends to have a ball of fibrosis and pneumonitis rather than a straight edge like we're used to with some of the other conventional beam radiotherapy.
Good.
Oh, sorry, Howard.
No, go ahead. Sorry.
Oh, sorry. Just another quick. Oh, sorry.
Yeah, go ahead. Sorry.
Oh, sorry. Here's another quick case. I know I'd shown another case of this. I'll show you the case that I showed a couple of weeks ago. This is a patient with Loeys-Dietz syndrome, which you can think of as a connective tissue disease that is somewhat similar to Marfan's in the sense that it causes early aortic dissection, and it causes another ectasia of the root and ascending aorta. The other thing that I was curious about that I had not heard of before is that it actually causes vessel tortuosity. So this is a young patient who had enormous tortuosity of the vertebral arteries bilaterally, and I showed this a couple weeks ago. Here's another patient who came in with Loeys-Dietz syndrome as well, and I'll show you just the MIFs from the MRA that the patient had. And in an older patient, might not think that much about this extremely cloister-like appearance of this tortuous splenic artery, but I tell you, this patient is only 27 years old with Loeys-Dietz syndrome. This is a significant amount of vessel tortuosity, presumably due to the disease itself. And I don't have the accompanying head and neck CT images, but this patient had enormous tortuosity as well of the vertebral arteries and the internal carotid arteries. So again, I mean, this is just not just, and of course this patient had a little bit of an aneurysmal aortic root as well. So so I now looked for vessel tortuosity in all these patients, and there's some papers out there that postulate that it has prognostic indications for these patients as well. You can see that the arch has a somewhat high kind of abnormal appearance as well, which is presumably part of their overall disease. So just vessel tortuosity, something I hadn't really been attuned to in Loeys-Dietz before these cases. So that was just a quick case. Here's a case courtesy of Ann Duong, who's sitting right next to me right now. This was a gentleman who came in to an outside hospital, and I'll withhold some history here for a second, but presented in the subacute setting after about 5 days of onset of symptoms. And I'll just scroll through the heart first, and you see abnormality here involving the left ventricle, and you can see that there is low attenuation along the apex of the left ventricle that has these angular margins, and this is all actually lamellated thrombus that is formed within the left ventricle. You can see that it's a little bit lower attenuation than the rest of the myocardium. In fact, the myocardium here at the LV apex is not enhancing well at all. So we start thinking about a myocardial infarct in this patient. And I'll show you the coronaries starting from the top. Here's the left main. And then you can see that there's a complete occlusion of the LAD, the proximal LAD. You can see a little bit of trickle of presumably some contrast coming from collaterals here, but then the LAD is really not pacifying at all, maybe some backflow into a diagonal branch here. So this patient had a complete LAD occlusion with an ST elevation MI that went kind of delayed in presentation. The history is that he was a runner and had some chest symptoms and didn't think that it could be an MI due to his general overall health. So this was a delayed presentation, had a cath at an outside hospital, and by that time that he presented, about 5 years after the acute event, they deemed that this was not really amenable to revascularization, and so they left this. You can also see that there's some enhancement of the pericardium and some stranding around the pericardium. So this is a post-MI pericarditis as well, in keeping with Dressler's syndrome. So just a very dramatic case. You can see that there is an intra-aortic balloon pump as well, an interesting thing that we don't get to see on CT a lot of the time, but you can see that it's opening during diastole and closing during systole. And so this is just a dramatic case of a kind of subacute presentation of an MI with complete occlusion of the LAD.
Wow. Hey, Brent, is his calcium score 0?
Well,
calcium?
I don't. Do you remember? Oh yeah, they didn't do calcium score. I mean, I don't see any calcium, but it's it's possible that this is a drop of calcium, but it's also possible that Anna's telling me that they didn't do it. It was in the. This was done to try to assess for wall rupture of the LV. So there's some irregularity here, and so you could wonder, could there be some propensity or developing wall insufficiency here? So, but yeah, I mean, it's possible the calcium score was 0 here.
Yeah, maybe he's one of those rare patients that has a 0 calcium score but still has non-calcified plaque, because I didn't see any when you were scrolling through.
Yeah, I mean, some studies show that 10% of patients would have with MIs would have a negative calcium score. So sorry, I interrupted someone. Was somebody else commenting?
No, I was just saying we see MIs not infrequently in people with 0 calcium scores. Not.
Yeah. I mean, the figure that's I forget which paper this was, but the figure that's has been quoted to me was somewhere around 10% would have a negative calcium score when you do catch them. But I thought that was true.
Seth, those guys across the city at Hopkins, one of my friends who's a cardiologist there is a big advocate for coronary calcium as a 0 calcium score being very unlikely to have coronary disease, but that's across town.
I disagree. Obviously, acute MIs are not due to calcium buildup, it's due to plaque rupture, and calcification of plaque has nothing to do with rupture. And you can get people with non-calcified plaque that ruptures, and actually, as we all know, the plaques that tend to do more damage are the ones that either have no calcification or the ones that have spotty calcification. So,
I agree with you. Yeah.
And that's our kind of feeling around it here, and that's a lot of this. Anyways, yeah, I mean, commonly you see people have a ton of it, but I'm telling you, a young guy, it's not uncommon to see someone who's in their 40s and 50s with a massive acute occlusion that has a 0 calcium score.
Yeah, I'm not arguing with you. There
Yeah.
are people that have another school. There is another school of thought that some people try and advocate just doing calcium scores and getting away with that. But
Yeah, no, and the theory is that they say, well, if you have a 0 calcium score, your 5-year incidence of a MACE is like 3 or 4%, but that's and that's true. It's less likely, but it's not 0. Anyways.
Yeah, I mean, I was always trained not to use that as a 0 calcium score as any sort of exclusion for suspicion of acute MI, but for those reasons. But okay, so this is kind of the last case I have. So here's the SCOUT view, and you can see this is a relatively young patient who has a lot of nodules just scattered. You can see on the SCOUT everywhere. Let me show you an early CT from 2008. This is I'm withholding the history here. But you can see lots of central lobular nodules sparing the pleura here. They're dramatically distributed throughout all lobes in a very symmetric, diffuse manner here. And so this was 2008. And we have a more recent CT here. And this is
is there pulmonary hypertension on that 2008 scan?
Let me remind myself if there was at that point. This case is courtesy of someone else who's sitting right here, Bill Offerman, and he showed me this case.
Pulmonary.
And here's the pulmonary artery. Here at this point, it was enlarged.
Yep.
It's one thing we're starting to think of the diagnosis here. And here's the follow-up from just recently, where you notice that all of those central lobular nodules have increased in size and are quite dramatic. The poster person for a kind of a central lobular pattern or even tree and bud pattern here. You notice some areas of confluence in the lingula here as well. And let's look at the pulmonary artery again. Certainly it's still enlarged. Let's look back at that. So, it's enlarged here as well. But the history I'm withholding is that this is a patient who had inflammatory bowel disease, who had partial bowel resection, who had short gut syndrome, and was on TPN. So this is, and this is presumably a case of excipient lung. Now the complicating thing is, I've noticed in a few of these cases that we've had with Travis and cases from here that we've all had, is that you don't really elicit a history of any sort of illicit drug use in many of these patients. And so I know there's some debate about whether the new TPN agents can actually cause this alone or whether they can't. It's likely that maybe you're not getting a full history of illicit drug use in some of these patients, but presumably this is a case of excipient lung, and they did do a lung biopsy on this patient and found some scattered particulate matter with cellulose in this patient. So presumably a nice case of excipient lung again.
Yeah, that one is really dramatic. If you bring up the original one that you showed, and just for fun, make up say a 5 millimeter MIPS.
Well, here are the MIPS from the more recent one, but look how dramatic that is.
Yeah.
Wow.
Yeah.
Just amazingly.
Yeah, if you can trace those.
I'd like to get a paper like that.
Yeah.
Oh, sorry, Howard. What did you say?
No, it's really nice. With MIPS, you can kind of trace. If you spend some time, you can trace the pulmonary veins, and if you see the pulmonary veins, then you can identify that those small branching opacities are between them, hence in the central portion of the pulmonary lobules. And then if they're branching, one can identify them as potentially branching pulmonary arterioles involved in that process. Yeah.
Yeah.
Very dramatic.
So anyway, those are my cases for this week.
Thanks, great. Seth, do you have cases you want to show this week?
Sure.
Okay.
There we go. I had one cool case. The other ones are not too fascinating. I don't remember what this case was. Oh, this is a cool case. So this was a something I had. Now the second time I've come across this in a patient with this diagnosis. So this is a young female who is I don't know, 18, 19, non-smoker, and has a history of juvenile rheumatoid arthritis, and has this really, really extensive cystic lung disease. And then it's hard to know what's going on in the lower lobes. You can tell by the endotracheal tube, she had started crumping at this point. It's hard to tell, and she did develop very severe ARDS, so it's hard to tell if this ground glass was her emerging acute lung injury, which I think it is, versus some form of underlying chronic lung injuries. But again, and I don't know if people remember, a while ago, I showed a case of a woman who was a quote-unquote chicken sexer, who had HP, but also had a history of long-standing rheumatoid arthritis, and also had this really pronounced cystic lung disease. And I do have the gross on her. So she was on ECMO for quite some time, and after ECMO, we got her lungs, and because she got a transplant, and you can just see these big cysts of varying size. Now, it was hard to tell what was truly going on in the bases in the parenchyma itself, because as some people know or don't know, that if you're on ECMO, this one was on ECMO for like 2 months to bridge her to transplant, and ECMO just completely trashes the lung. So, when you're trying to assess underlying fibrotic change that is native to extensive fibrotic change that is post-ECMO, it's really difficult to do so. So the pathologist called me and says, what the hell is this? And I said, I don't know. I was hoping you can tell me. And it was just a diffusely fibrotic lung, and there was nothing really that abnormal in the upper lobes except for that it was completely replaced by cysts. But it's just interesting that this is the second case of someone with rheumatoid that has had this just extensive cystic lung disease. And it wasn't he said it wasn't honeycombing, there was no there's no fibroblastic foci in the upper lobes. It was definitely not upper lobe honeycombing. It was just cysts. Has anyone else come across that at all? Has seen that?
No.
No.
So
Okay. No, it's just it's the second. It looks exactly like that chicken sexer case from a couple months ago, or maybe now a year ago. Very interesting, but okay.
strange, very strange.
It is strange. It is, most ILD is that we see is very odd and strange. This case, I'll save the best for last. This case is interesting only because of its historical, I don't want to say not importance, but historical interest. This is a woman. So Jatine was a Brazilian pediatric cardiac surgeon, and Jatine came out with, obviously before Jatine, people were doing the mustard and senning for an atrial switch. This woman is 48. So Jatine, this is a woman was from Brazil. So Jatine, before he actually successfully got his kind of, I don't want to say perfected, but he did this initial arterial switch, and a lot of the first patients who got it, in fact, all of the first patients who got it, I think all of the 10 or 12, they all died. And it was mostly due to issues with coronary reimplantation. She is the second person ever to have the Jettine switch that survived. And what's interesting about it is that we're so used to seeing a Jettine with the draping of the pulmonary arteries. So Jettine is done for a detrans, and normally we see the pulmonary arteries draping over the aorta. That's the classic finding, but that's actually called the Lecomte maneuver. So Lecomte, after Jettine kind of said, "Well, do this," he was noticing that they were having issues of compression of the PA. So basically, the PA is swung all the way over, and it's kind of pushed over and displaced by what is now the aorta. And so Lecomte came in and actually draped the pulmonary arteries over. So that is called the Lecomte maneuver. So it's interesting that we often think of that as the Jettine, but it's called the Jettine Lecomte. But anyways, this is just one of the very few living people, and one of the first to actually get an arterial switch procedure. And she's many years out. She's doing well, but she's having issues, which is, again, this is an outside study. She's starting to have issues because her main PA is now and this study's old. This is from like 2012. We have some MRIs, but there's a bunch of images. Her main PA is now being squished down by this aorta, which is getting a little larger to about 5-6 millimeters. So they're going to have to go in and try to fix that main PA. But I just thought historically that was neat.
Yeah.
And then this is the case which I thought was the coolest case, but the case I'm most upset about. So we had this woman with a right atrial mass. Now everyone knows most people get a right atrial mass. There's actually not a right atrial mass. So lo and behold, we get a patient with a right atrial mass, and sure enough, there's this large right atrial mass. Now, most commonly, this is not coming from the IVC. I mean, it's bulging into the IVC, but it wasn't coming from below. Most times it's a tumor or thrombus coming from the SVC or IVC. So initially I thought, okay, it's going to be, the most common right atrial tumor really that's primary it's still a myxoma, even though myxomas are most commonly left atrial. And left atrial myxomas are, let's see, so here's the T1 pre, with fat sac, quite bright on T1 pre-contrast, which is interesting, a little atypical for a myxoma. And then if I can manage to find where are you? I'm sorry, I'm looking for the T2. So look how bright this thing is on the T2-weighted imaging. I mean, it is like a light bulb bright. Oops, sorry. And now, myxomas, I've seen a lot of myxomas, and myxomas do have, because of myxoid elements, some bright signal on T2-weighted imaging. So I'm like, well, this is kind of atypical. And then I'm going into my differential of, extraordinarily T2 avid or T2 bright lesions, and you're in like paraganglioma, and this is really not a good location. Paraganglioma, it's just not the right location. It's obviously not a parathyroid lesion, and it's not Castleman disease. And then I was left with hemangioma, and I was like, well, this is right atrial hemangiomas. They're rare, but we've seen them. So we did perfusion. The thing slowly perfuses over time, and so now I have to sort it by time. So we did perfusion imaging, and the thing barely perfused to start. And so when we started imaging, if I can get it to go through without a ton of artifact, there was some mild perfusion, so definitely enhanced. And then we did a vibe, and you can see from the vibe that this thing is starting to enhance more. T1 post, shows that this thing is even enhancing more. So then I did a perfusion. Now we're about 10 minutes out after giving contrast. So I do another perfusion, and it's now filling in. We do our delayeds, which show that it's a mass, which we're not. And then I do a perfusion like 25 minutes out, and it's still continuing to perfuse. And so I'm like, well, this is, if I saw this in the mediastinum, I would call this hemangioma. So I was so excited to have a right atrial, what I assumed is perfectly characteristic for right atrial hemangioma. We actually even had an outside CT that was an abdomen and pelvis where they did a delayed phase. We catch the bottom of it, but you can even see like little punctate calcifications, which I thought were phleboliths. And you can see these little punctate calcifications in it. So I'm like, oh, maybe there's little phleboliths or something in them. So, I talked to as you were signing me up, I was trying to get the actual images, but I was talking to the pathologist, and I was like, you gotta, this is a hemangioma, you gotta get great pictures, blah, blah, blah. And so this was sent to me from him, and he's like, this is the most classic right atrial myxoma. So, unfortunately, well, it's still a neat case, but he looked through, he said it's weird, that it was almost all myxoid elements, and that explains the T2 intensity throughout it. But in fact, it was, just the myxoma, right atrial myxoma. Now, right atrial myxomas, unlike left atrial myxomas, this did not involve the septum. We have, I send along the SSFP sequences that show it clearly spares the septum, that it's rising from the lateral wall. But right atrial myxomas do that. Right atrial myxomas often don't involve the septum. But I've just not seen a myxoma be this bright on T2 weighted imaging. And I even Googled MRI right atrial hemangioma, and I had 3 cases that looked exactly like this. But it just goes to show common things being common. I don't know if anyone else who does some cardiac imaging has any comments about if they've seen a hemangioma or a right atrial myxoma be this T2 intense diffusely. So learning, I guess, the old saying goes, it's an uncommon presentation of a common lesion versus the other. But it's a cool case nonetheless.
Yeah. No, I haven't. That's really interesting.
Travis, have you seen that before? Are you paying attention?
He may have had to step out. He said that he may have to.
Yeah, I'm sure he probably stepped out. But anyways, those are my cases.
Great, thank you. No, that's really interesting. Okay, I will show 2 cases, say, and then we'll come back. So this particular case is very interesting. There are a lot of images there, but let me start by giving you the context. So the context, as I'll show you in a moment, is a young person that presented with initially oral ulcers. And after that, she also developed skin lesions. So, of course, she went to dermatology, and these apparently were quite severe. And after evaluating her and subsequently doing an initial biopsy, they still weren't certain what the diagnosis was. At a later time, I think they may have gotten a second biopsy. And in the differential for that, they included pemphigus, but also paraneoplastic pemphigus. And then I believe that was responsible for the performance of a CT. I don't think she had any abdominal or chest symptoms at that time. Let me just make sure I'm getting the order right. So this is part of her workup after she's been diagnosed with potentially pemphigus. And there is this lesion. So it's very large and it's very intense. It's very bright. So they were thinking about paraneoplastic pemphigus, and there indeed is the neoplasm. And it turns out that of the tumors associated with so-called paraneoplastic pemphigus, non-Hodgkin lymphomas and Castleman's disease are the most common. And certainly this is consistent with Castleman's disease, unicentric, of course, and one would clearly suggest the so-called hyaline vascular pathology type of Castleman's disease. So that indeed was biopsied, and I'll show you in a moment that that is indeed Castleman's disease. So she was diagnosed with paraneoplastic pemphigus, and they, I think, started some form of treatment. Now I want to go back and show you the chest radiograph. And initially when I saw this in bits and pieces and didn't really make the comparison I'm going to show you here initially. So let me bring in a chest radiograph later when she has some other issues. Let's see if there's one in between here actually. So let me go to the initial one and this comparison. So here we're about a year apart, and just ignore for the moment that she has pulmonary parenchymal disease, which I'll get to in a moment. But if you look at her lung volumes, she clearly is now really hyperinflated. So she has findings on even the chest radiograph suggestive of obstructive lung disease. Let me go back now and put the CT from before up against the CT done here. So this comparison now is between April of 15 and, sorry, I want to get a later one, December of 15. So here we have, and I don't want these to scroll, nice looking lungs in April. But if you look at her lungs now, at the time when we know she's hyperinflated, now I can bring this up separately. Not only is she very hyperinflated, but she also has bronchial wall thickening and some degree of bronchial dilatation involving proximal airways. But this is a very diffuse process. There is subtle mosaic attenuation, a little bit, in the lower lung zone, but mostly her lungs are diffusely affected. So she has findings of severe obstructive airways disease. So now let me just bring up the history just to get some context here. So she presented initially with the skin lesions and edema and so on. She had the biopsies. She had the biopsy of the mass that showed Castleman's disease. And then here you can see a comparison between her PFTs in April 2015 and 2016, showing severe obstructive airways disease. And then she was treated with a bunch of things. And then just to sort of add insult to injury, she really experienced a bad complication of therapy. So she presented pretty ill at this time. Now she has extensive parenchymal opacities and bronchial disease. And at that time, I was kind of convinced that she may have had reactivation TB and bronchogenic spread. But this turned out to be Aspergillus infection for which she was treated. And the folks thought that the predisposition to get this was new hypogammaglobulinemia, which they blamed on the therapy. So this is a really classic case of this entity that Dave showed us before. It's called paraneoplastic autoimmune multi-organ syndrome. And it turns out that one finding that you can get is lung involvement. So let's see if I can quickly get there. If I can't, I can tell you that bronchiolitis obliterans is described with this entity, and it can be really severe. Here you can see in that one paragraph there the idea that the columnar epithelium in the bronchioles are a target of these autoantibodies, resulting in bronchiolitis obliterans, as you can see there. So she's young and she's really in trouble from the point of view of this. I don't know how effective the therapy is going to be, but a pretty dramatic case of paraneoplastic pemphigus, Castleman's, and severe bronchiolitis or constrictive bronchiolitis.
That's pretty cool. So Howard, when you see a case like that, I mean, when I see when you show her, just clear destroyed airways, I read that as findings suggestive of constrictive bronchiolitis or obliterative bronchiolitis. Is that how you stated, or what do you say? Do you say just severe, large and small airways disease? What do you like when it's that bad? I usually actually invoke obliteration or obliter bronchiolitis. Do you
Yeah,
do that as well, or
for this particular one, when
the one before she was infected? Yeah, this kind of
yeah,
severe airway, large and small airway involvement. You could when I see something like this, I really I personally say it's concerning for obliter bronchiolitis. Do you ever go that far? Do you just say severe,
yeah,
small, and large?
like you think I would think about it. I mean, so, usually we look for mosaic attenuation, but if it's very diffuse,
When it's so severe, you're not going to see it. Yeah, I mean, there's like a few little patches of normal
right,
lung.
exactly. Every lobule here pretty much is trapping air, just diffusely and
Yeah.
severely. Yeah, that's the challenge. And clearly, when you have a comparison and you can see these airways dilating up, it's helpful. So, yeah.
Yeah, I'm just curious how other people word it, like how other, I'm always curious how the vocabulary others use.
Yeah, I would certainly suggest constrictive bronchiolitis
Okay.
as an etiology. Yep.
Howard, we had a case that was also where there was a lot of talk about pemphigus, and it was a thymic tumor, and this person had constrictive bronchiolitis, a lot of airways disease, very short of breath. So that was the perineoplastic syndrome where I've seen this similar thing. There was a lot of talk about pemphigus in that case as well.
Yep. And it can be so severe that they actually develop cystic parenchymal lung disease as well, presumably just because of progressive hyperinflation. And I'm not sure exactly what the mechanism is, but they can develop frank cystic lung disease too.
Valve kind of stuff.
Yeah,
Maybe.
I think so. Yeah, I think this is the kind of lung where the pathologist looking at it will just look, and if they're astute, they look for bronchioles, and they can't find them.
Yeah.
They can't find bronchioles. They can find the lobular arteriole and look for the adjacent bronchus, and they can't find them. And there's just a massive dropout and disappearance of bronchioles. Yep. Yep. Yeah, that's the first case that I've seen like that dramatic. This one's really nice because I have a picture for you. So this is a patient that had, just to make things relatively quick, the cardiologist knew there was a problem with a lead and also knew the type of lead that was present and brought the patient in for replacement of a lead. So let me see if I can show you the radiograph first. And there's that one, but let me bring in another one and see if nope, that's after the leads have been replaced. So let me try and bring in this one. And just bear with me as I mag this one up because the finding is really subtle. So really, if you know there's a lead problem, or if you're looking for a lead problem, you've got to look for things like this. And here, in relation to this right ventricular lead, just from about there to about there, this conducting electrode is displaced away. And that is a phenomenon called externalization of a lead. And let me show it to you to better advantage on the procedure. And here it is here. Let's see if I scroll whether we can see that a bit better as the heart's beating, but you can see the displacement there. The other thing that this person also had that the cardiologist picked up on was, and let me bring this over here. So this is the coronary vein lead, and I hope you can see this because occasionally you can see a little faint shadow right there, just in this curve of the lead there. Let's see if I have another one in which that is shown a little bit better. Perhaps not that one, but, well, maybe it's the only one that really shows it is this one. So again, I have to really zoom in here, but occasionally you'll see appearing, like right there, between that frame and that frame, there's a little lead there, and he thought that was also externalized right there. So this is the actual photograph of the right ventricular lead. Of course, now it's all crumpled up, but what we're seeing is this blue thing that's completely outside of the insulation. And in relation to the right ventricular lead, that's called externalization. So there's a notorious lead called a Riata lead made by Medtronic, or St. Jude that failed in this fashion or sometimes fails in this fashion. And this is a really nice example of that externalization phenomenon in relation to that lead. So again, it's just being able to see this kind of subtle thing right there. And then I have another picture here, which he said is not the same patient. Let's see if I still have it. That is a picture that he sent to me that from a meeting that he attended. And this is an externalized conductor in relation to a coronary vein lead from, I think, a meeting or a lecture that he went to. And he also found this one in this patient, but it's really quite subtle. So that's what an externalized conductor looks like. All right, Travis, are you there?
Yeah, I can show a couple.
Okay.
Assuming nobody else comes into the room.
All right.
All right. These cases are not that subtle. I'll start with this one. This is a patient who, let me make sure I get the order right here. She had an aortic valve replacement, and I can't remember the exact reason why. I think she had endocarditis, but this was back in 2014, and this abnormal flexion was described near the aortic annulus, and she's post-operative. She had an anastomosis there, and in fact, I think you can even see the communication right here. So this was described as a small pseudoaneurysm, likely at the anastomosis of the aortic valve. And I don't know exactly the story of what, they decided to watch it at this point. And then she came back in October of that same year. So this was about a 6 or 7 months difference. And I think the radiograph's kind of interesting because here's the more recent radiograph. And here you can see the aorta, and now you see aorta, and then you see this extra big convexity. And you don't lose the aortic stripe here, so telling you it's not along the distal aortic arch and descending thoracic aorta. We don't have a lateral view, unfortunately. But as you might suspect, that her CT at that time, she now has a little bit larger pseudoaneurysm, still coming from that same place. You can even see the communication with the difference in contrast attenuation. And at this time, she did come in with some palpable abnormality in her anterior chest wall, as you see here. And what's interesting is you couldn't even see a dehiscence of her sternal wires because the wires themselves are still aligned, and this thing is just eating through her sternum. Fast forward to 2015, and she was too sick to get surgery at that time, or chose not to get surgery. And so now you can see that this has continued to enlarge, and on this CT in 2015 now, she has the contrast is even going through the sternal wire now. So this is just progressive enlargement of a huge pseudoaneurysm. Of course, especially in older literature, this has been described being able to erode through sternotomies. But they did eventually go and repair this. But it's just an enormous, the biggest pseudoaneurysm I've seen going up along the ascending aorta and out through the sternotomy. So, and we have a nice natural history. I have shown a case where it looked similar to this in the ascending aorta, where it was a patient that had had a graft called a recurrent dissection, just because the pseudoaneurysms can track up along and simulate a false lumen versus a true lumen, but obviously that is not the case in this example. So,
and Travis, this was not infected. This is just the hemodynamic effect here causing this erosion and bulging.
Yeah, I don't think it was infected. Patients, who knows why she ended up with this little dehiscence to start with. Maybe there was a little subclinical infection at the anastomosis. I don't know. But this whole thing was not infected. She never had infectious symptoms.
There's those famous old cases of syphilitic ascending aortic aneurysms eroding through the sternum and appearing, under the skin. The chest wall was like, it's like an empyema necessitans, except it was aorta necessitans or something.
Yeah.
There was a better name for that.
Certainly not.
It's hard to believe that a hematoma will actually erode, in a sense, erode through bone. It's just...
Yeah, that's a good point. But yeah, there was never any, she never acted infected. There was no discussion of that. I think that's a valid question.
Strange.
I don't know the answer.
I think that much, it's almost near systemic pressure. I think over time, it could definitely erode through structures.
Yeah. This case isn't that exciting, but it's a more recent one I saw a couple weekends ago. A lady that has a pseudoaneurysm. She also had valve surgery, and she had a myxoma. That's what it was. She had a myxoma that they resected. That's not the exciting thing.
This one looks like it.
It's
accurate. Is that a graph?
And again,
Travis, we can barely hear you.
Oh, is that better?
Better.
Okay. Why I preach again on these portable radiographs in the ICU immediately post-op that it's more important to, or the lungs are the least important things. Here you can see now that in this case, her sternal wires markedly displaced, and try and remind the resident the atelectasis and/or effusion of tears not nearly as important as recognizing this, because this was unsuspected clinically at that time. We did have a white count, and they never even did a CT.
Well, in other words, they're not lining up. That one looks like it. If you well,
so, just a nice example of a sternal dehiscence in the postoperative period.
Wires.
I'm going to show one more, and that's it. And this is the case I sent out to Howard a couple of days ago. Actually, I need to go deal with a consult here, Howard. Sorry.
Okay, we can save that one. That's fine. Okay.
Howard, I can show a case.
Excellent. Okay. David, here you go.
So if you're looking, I think this is baseline data. Everything's lined up, and then if you look.
So this is a new cardiac device, at least new to me, so I'd like to ask you guys whether you have seen this before. Can everybody see a screen here with a chest röntgenogram?
Yep, we can see that little guy.
So there's this little device here, and I thought that this was one of those subcutaneous event recorders that they like to implant and leave in place. But the cardiologist called me later on and told me that this is actually a leadless, self-contained pacemaker that is placed percutaneously into the right ventricle, has 4 tines at the end here, which cause it to embed in the right ventricular myocardium. And this will pace the RV for people with bradycardia, and it lasts 10 years. So it's got enough battery supply to go for 10 years. I'd never seen a device like this before. Have you guys seen this thing? It's called Micra. It's from Medtronic, and I think it was just recently released for implantation by the FDA.
Yeah, I know. I think it was called. It was called Vivo.
I've heard about this. Is it still investigational? I've heard about it coming.
It's actually out there now, I think.
That it's been approved. Can you just make that up a little bit?
We've actually been seeing these for like the last 6 months to a year. I think we have many patients who have these now.
Can you see the little curved tines at the end? There, it looks like a hydra. Those are the things that implant it. So Brent, they're already using this. They've been using this thing for months now at your place.
We have been seeing them for at least I think the last 6 months or so, or more. So I think because we're a study site as well. So.
So
okay, I have
great. Yeah.
Another case to show you guys. This is a woman who has these long-standing, large basal lung nodules here. Very, very smooth and sort of bizarre configuration to them. Some low attenuation stuff in the center. And these are relatively stable now. This current exam was this month, 2016, but these go back to 2008. And, turns out that months before or years before, she'd had complicated uterine surgeries for large leiomyomas of the uterus. They find that there were some elements of those tumors when they resected the uterus that were intravascular, intravenous, and presumably that is the cause of these. These lesions were biopsied, and these are leiomyomas. So this is benign metastasizing lyomas of the lung. These large basal lesions have been.
But they're not past proven either.
No.
That's pretty cool.
Yeah, that's really interesting. So perhaps their dissemination was facilitated at the time of surgery, or in this case, maybe?
Yes, that's usually the case. Most of the people who develop the spread of leiomyomas to other parts of the body did have surgery that jostled, the tumor and probably launched it into the venous system. So almost invariably, there is a history of surgery in these cases.
We had a case a couple of months ago. We just couldn't. They biopsied a bunch of them and they didn't get a diagnosis, but it was the same history. Big, huge fibroids taken out and developed them immediately, a few weeks after surgery, and they've been stable.
Right.
That's really cool. That's really nice. You have tissue on it.
And again, on the mediastinal window, are they low attenuation? Just curious.
Yeah, they do seem to have some low attenuation stuff in them. Let's do an ROI here. Just do an E. So a mean of 6. So it looks almost myxoid again, doesn't it? Sort of like the way a leiomyoma might, with low attenuation stuff.
Yeah, I've not seen ones that big. I mean, the one or two cases I've seen, there were, like the one in the left lower lobe, a little smaller. That's neat.
Okay, Howard, those are the two.
Okay, great. Let's see. Travis has a great case, I know, but he'll have to probably show it next week because he's busy there. Well, perhaps this is a good time to end this week's session, and I have some other good cases too that I can show next time. So, yep, let's quit. It's almost 2 o'clock my time. Travis, if you're still there, we'll get you a case. You'll be first on next time.
Thanks.
Thanks,
All right,
everyone.
thanks, everyone. Bye.
Bye.